Okay, so now we're going to move into chapter 7. Let me get it queued up. Go ahead and share my screen with you. All right. Okay, this is a pretty lengthy chapter with a lot of material, so we're going to dive right in. And after studying this chapter, you're going to be able to discuss the relationship between the principles of asepsis and practice of sterile technique and surgical patient care. You'll also be able to discuss the concept of surgical conscience and define that, and the principles of asepsis and the terms related to asepsis. Talking about different sterile practices related to the principles of asepsis, and identify the principles and procedures related to disinfection and sterilization. There's several of each of those. Demonstrate competency related to the practice of sterile technique. Demonstrate competency in the procedures related to disinfection and sterilization. And then discuss the surgical environment and the application of the principles of asepsis through the environment. Okay, so as we move into sterilization, disinfection, all that, we have to think about what are we trying to eliminate. So of course, the primary thing is microbes, and microbes are in 3 broad categories. They're broken down in each of those, but prokaryotes and eukaryotes and viruses. Microbes do include non-pathogenic and pathogenic, of course, and then parasitic life forms. So one thing that microorganisms do is that they convert the organic compounds into more simple forms as they're decaying. So that process creates its own set of challenges. So there are some human microbe relationships, and those do include things like symbiosis, mutualism, commensalism, parasitism, and pathogenicity. And we're going to look at the box 7.1 as it goes into each of these a little bit more in detail. Just one moment. Okay, let me stop the share and start that again so that you can. Let's get into the book here. Here's on box 7.1, where we look at how each of these work. I think I had went into these a little bit more. Yeah, I did. So the mutualism, this is where both of the organisms are going to benefit and depend on each other. An example of that is E. coli. It normally colonizes in the intestines, where it obtains nutrients from the food that we eat. It also gives us a benefit of producing vitamin K. And that is something that is essential for blood clotting in humans. And so anytime that there is a blood clotting issue, this is a situation that is looked at as far as how the E. coli colonization is occurring and if it's interfering with that blood clotting process. Synergism, so the synergy is a subcategory of mutualism. This is where 2 organisms work together, and this is to get a result that neither one of them could obtain alone. So we could obtain it without, or the one bacteria couldn't obtain that goal without the other. So an example is Fusobacteria and spirochetes. They work together and they cause a disease called trench mouth. Commensalism, this is when one organism benefits, but the second organism neither benefits nor is harmed. So it's not going to be harmed, but it's not going to benefit. An example of this is our normal indigenous microflora on the skin. It obtains nutrients, but it doesn't affect the skin or the human body. And so this is just they do occupy space on the skin, and they allow that space to be occupied so that other microbes cannot colonize on the skin. And so this is when they're doing that, that's competitive exclusion, where the healthy indigenous microflora on the skin is taking up the space that the pathogenic kind of microbes are trying to occupy, so it prevents them from getting into that space. So that's competitive exclusion. Mutualism, so this is a subcategory of the commensalism, and this is where two organisms occupy the same space with no effect on each other. Antagonism, just another subcategory of commensalism, and this one microorganism inhibits or interferes with the growth of the other. An example of that is when a microbe produces waste products that's toxic to the microbes nearby. So there's a lot of microbes that, as they're going through that process of decay, they will create waste products. And those particular waste products will kill out some of the other microbes that are nearby. And then we have parasitism, and we've all heard of parasites, but parasitism is when one organism is going to benefit, which is usually the parasite, and the host is harmed, which is in our case, the humans. And an example of this, endoparasites. So there's a lot of different types of intestinal worms, and they'll cause infections, and they also deplete the body of nutrition. So like an example is a tapeworm, and they're not necessarily going to create an infection for the most part, but they will deplete the body of nutrition. And so we have to take all of that into consideration when we're looking at what these pathogens are doing. Now, any microorganisms that cause any type of infection, they are called pathogens. And then you can see that there's different types of pathogenic relationships. So going back to the commensalism, these types of microbes that become opportunistic, they'll enter through the skin and through the surgical site. Nosocomial infections, and this means nosocomial means infection acquired in a hospital. And so those are, the most common is a UTI. And so those are monitored frequently. And all of your surgical patients are going to have a urinary catheter unless it's a very short case. And so those are a site for a possible nosocomial infection. Airborne infections, of course, these are the viruses that are airborne, such as the common cold, the virus that causes common cold, virus that causes flu, the virus that causes COVID. So all of those are airborne viruses. So let's start with the surgical site infection, and this is one of the most important to you as a scrub. So as we said, multiplication or nosocomial infection, so that's anything that happens while in their healthcare facility. It's hospital-acquired infection. And this is where there is a multiplication of organisms in the tissue around the surgical site. A host, of course, means a patient. Some of those pathogens could be bacteria. And one form of bacteria is the prokaryotes, and they divide by what's called binary fission. And so that's just that they're separating into two then. And they're classified on those characteristics in the laboratory. And I'm going to switch back over to see, it's table 771. So let me get over there so we can look at that table. There's a ton of different types of SSIs, as they're called. That's a surgical site infection. Here's the table. So we're looking at the different morphology, which means the size, shape, and arrangement. So we have coccoid, and these are round. Coccus is singular form, cocci is plural. So diplococci, streptococci, staphylococci, and coccobacilla. And you can see there's different types. So there's paired, chain, cluster, and then this is in between, basically. Bacillus is rod shaped, spirula is spiral shape, L form. It makes sense, it's L form. It kind of loses shape. And And then we also categorize them by their form, by their growth. And so it depends on how they're going to grow in an agar medium. So shape, size, and color going to be specific to the bacterial species. And the rate at which the bacteria multiplies is a key characteristic. So all of this is taken into account in pathology when they're being looked at under the microscope. Motility, so how able is it to move by itself? So they have different structures. One structure is a flagella. So that's that long, thin structure that you're familiar with on the end of sperm. That is a flagella on the end of sperm, where cilia is fine hair-like extensions, as we see in the lungs, we see that in the digestive tract, things like that. But cilia can also be on a pathogen to help it move along. It's that rhythmic flow. And then we also look at nutritional requirements. And so it depends on what the pathogen needs to thrive. Is it carbon? Is it oxygen, sulfur, nitrogen, hydrogen, so on and so forth. And so that helps in the identification of it to know what helps it grow. Oxygen requirement is, does it need oxygen, or is it anaerobic? Does it need carbon dioxide? Obligate aerobics or aerobes, they require oxygen. And so, and you can see the different ones, obligate anaerobes, they will not grow if there's any oxygen present. So you can see there's different things that are taken into account. And then the pathogenicity. So this is how capable are they to cause disease? And so you can see the different things that they take into account there. And then metabolism, the secretion of waste products, protein. Some of the microbes are made up of certain amino acid sequences. So this is used to determine the relationship of the species to other types of bacteria. And then DNA is unique to bacterial species. Now, staining is a major way to see what type of bacteria we're looking at. So a simple stain, this is just looking at the shape and the structure. The most common one is methylene blue, and then it's rinsed with water. Now, gram stains, and you'll hear gram negative, gram positive, these are stained with crystal violet, and then it's washed with ethanol, so alcohol basically, and that removes the purple stains from bacteria that don't retain the stain, okay? And then a red dye of safranin, is applied, and then it's rinsed with water. And so the bacteria that retains that crystal violet, and so then it is a purple color, those are called gram positive. And then gram negative do not retain it, and so then they're red from that safranin stain. The Mycobacterium tuberculosis is what we call a gram variable, and then it means it doesn't stain red or purple. And then an acid-fast stain, these are used to identify mycobacteriums. As we just talked about, those are not going to stain red or purple. So in this, a red dye, a different red dye, carbofuchsin, is used on those acid fast. And then we have spore forming bacteria. Clostridium is one example of that. And that is, Clostridium is one of the pathogens that's caused from a lot of antibiotic use. So those are some of the most common, and then, or that's how they're determining. And then this next table is some of the most common bacteria. You can see here is Staphylococcus aureus, and this causes toxic shock syndrome along with osteomyelitis and endocarditis, and that this is a big one for post-op SSI. So because we normally have Staph aureus on our skin, we want to make sure that we're not creating any passageways for this to get internally where it can cause a problem. Staph epidermis, this is also from IV catheters, UTIs, any prosthetic device infection, as well as subacute bacterial infection and endocarditis. And then we've got the Streptococcus family. So we've got Strep pneumoniae, Strep pyogenes, Strep agalactia, and Strep mutans. And so you can see these all cause different types of results. And then we have the aerobic. So these are oxygen requiring gram-negative cocci, Bordetella pertussis, Neisseria gonorrhea, Neisseria meningitis, and then Moraxella. And so these you can see are a lot of different childhood diseases as well. So including PID, that is not childhood. And then aerobic gram-positive, here's some examples of those, and so on and so forth. So I think we've covered the major ones that will be in your wheelhouse. So, but here are some of those that are most commonly associated with the SSI. So Staph aureus, of course, is the number one. It's already on our skin. So we're looking at 30% of SSIs are caused by Staph aureus. Coagulase negative staphylococci, this is 13.7. Enterococcus species is 11.2, and then E. coli 9.6, and then it keeps going down. So you can see that there's a lot of different types of bacteria, and then also a lot of bacteria that you're going to be dealing with in the OR that you may not be aware of. So again, you can see more reason that it's important that you are always wearing your PPE to protect not only yourself, but your patient. We talked about this a little bit. Tuberculosis, it is caused by Mycobacterium tuberculosis bacteria. It is transmitted airborne through droplet nuclei. It not only affects the lungs, which is what most people think about, but it also affects the kidneys, bones, joints, and skin. There's a lot of isolation precautions that are taken with TB positive patients, including a negative airway room where the air is actually sucked out of the room instead of pumped into the room. And so this is a really big way to help remove that airborne bacteria that is going through the room. So that's going to be our first key word is negative pressure. And so remember, TB needs negative pressure ventilation in the room. And then viruses, these are non-living, where the bacteria is living, but a virus is non-living particles that, because they are reliant on the host cell for survival. They're not living at all until they get into the cell. And so they need the host to survive. Okay. Oh, just one moment. Okay. Okay, so we can look back in the book at some of those unique characteristics of viruses. Let me move on into this next one. We're going to look more into TB in we did in chapter 4. All right, so here are some of the characteristics, and you can see here, I think I put a picture. Yeah, here. So here we've got the most internal part. This is the genetic material capsule. So this is where the DNA basically of the virus resides. It is surrounded by a virus particle. And so this is the working material. The matrix surrounds that. Here you can see the capsule that is surrounded by a matrix. And then there is proteins on the outside, which makes up the envelope. Now, just a little side note, the vaccine for COVID is one of these, they're called spike proteins, where a lot of, like the flu vaccine, they're injecting the genetic material. And so that kind of helps you understand a little bit different, because they're taking the different strains of flu that are the most common in the last few years, and they make a compilation of that basically to inject as the vaccine. The flu vaccine is the genetic material, whereas the COVID is the spike proteins, which allows your body to build antibodies. So that kind of helps you understand a little bit about how viruses are. Now, this is a viral cell, not your body cell. So this viral cell will actually insert itself into your own cell. So these spike proteins will land on a receptor, and then your body's, your cell receptors will accept it, and then it enters the cell, and then it begins replicating this inside the cell. And so that is the makeup of a virus. And as you can see, there's different ways that they enter the body. They can get through respiratory droplets, body fluid exchange, ingestion of contaminated food or water, or bites by infected arthropod vectors. So those are some ways that we can see a virus infection. And you can see here's some common viral pathogens in the OR. Hep B is number 1. Hep C, Hep D, HIV, HSV, papillomavirus, CMV, and CJD. Okay. All right, let's get back over here. So there are emerging infectious disease in increased amounts. And this is because people are more mobile. You know, there's a lot more people traveling to different countries and getting exposed to things that their immune system was not prepared for, because our immune system kind of prepares itself for things that we're the most commonly exposed to. We also have an increased amount of bacteria, multi-drug resistant strains, and these are called MDRs. And then also the viruses have abilities to mutate. And we've definitely seen that with COVID. You know, I think we're on our 5th mutation now. And so they're very adaptable and they're able to mutate and adapt to the environment. And Ebola and COVID are 2 of those primary examples. This upper one is the COVID virus. And you can see here is the E protein, here's the M protein, an H protein, an S protein. There's a lot of mutation that can happen. Here's the Ebola virus. And you can see it is amongst the red blood cells here. So 2 of the most mutating viruses that we've seen. And then there's prions. Prion is a proteinaceous infectious particle. It does not contain DNA or RNA, so there's no genetic material in this pathogen. Excuse me. And what's unique about this group is that the transmission occurs from animals to humans, and these attack the neurons in the central nervous system. And so the thing that you need to be aware of is that the prions are transmitted through contaminated surgical instruments, and these are handled very specifically in the OR. It is not contagious, meaning if you're not in any of these cases where you are taking the prion in directly, then there's not really a big chance of you contracting that. So we just talked about CJD a little bit in the last slide, but that stands for Creutzfeldt-Jakob disease. And this occurs when these prions that we just talked about are in sheep and goats or in cattle. And in cattle, it's called mad cow disease, but when it's in humans, it's called Creutzfeldt-Jakob disease. And so what happens is the human body is going to produce that protein similar to a prion. And but what happens is it's different than that of an infectious prion. And so those changes turn into a infectious folded shape, basically, with that infection happening. And it happens very slowly. And it can be, then incubation can be up to 20 years. So here is what I wanted to go over with you. So there's some sample guidelines for suspected or known CJD patients. All units will be notified, including every department. All unnecessary equipment and supplies are going to be removed from the OR. And then everything that can't be removed is going to be moved as far away from the OR table as possible. Every piece of equipment is going to be covered with impervious sheets, including electrical cords are going to be covered in plastic sleeves. Everything's going to be covered. During the case, all the equipment and the instruments is going to be disposable if at all possible. They're not going to use power instruments if they can get away with that, because that will definitely aerosolize those contaminants. A neutral zone will be used when passing sharps. Then your attire is going to change a little bit because you're going to use double gloves. You're also going to use face shield, and then you're going to use the knee-high impervious shoe covers. And this is just to avoid any chance of any contaminated material reaching your toenails, or any cuts you may have, or any skin area that has broken integrity. And then you're going to clean all blood and body fluid spills with sodium hydroxide, which is household bleach. And then you'll be changing gowns, gloves, suction tips, and ESU tips as they're contaminated. Any specimen container is going to be not only marked as you normally would, but it's also going to be marked with CJD precautions on it, and it's going to be placed in a biohazard bag. And if requested, then you're going to use 1 molar sodium hydroxide at the end of the surgery on the patient's head to do a cleaning. Post-op, all of your instruments that are reusable, you're going to place in an impervious container in a biohazard bag, label it possible CJD, and handle that according to the hospital policy. And it may include disposal, you know, even though it is reusable, they may choose to dispose of those. If we're looking at body fluid and liquid waste, those are going to be collected, labeled, and bagged in biohazard, and you're going to label that with that possible CJD. Those are going to be kept separate from your normal waste bags, and then notify environmental services, because they will immediately come and collect that and incinerate those bags. And then the disposable supplies, like your surgical attire, drapes, sponges, those will all go in biohazard, and that will also be labeled possible CJD. And again, it will be kept separate as well. So keep in mind, environmental services is going to come and collect all of that material, and it's going to be incinerated immediately. Now, sharps, these are going to be done a little bit different because they're not incinerated with the other things, but they're going to be placed in separate sharps. They're not going to go in your normal sharps container that's in the OR. They're going to go in a separate one, label it possible CJD, and then that's going to get incinerated as well. Environmental cleaning. So environmental services will have to be, as everybody will be notified of the CJD possible case. And so at the end of the case, you're going to help contaminate the OR surfaces with that 1 molar sodium hydrochloride. And then it's going to soak for 60 minutes and then rinse with water, and then it'll be cleaned in the normal way. If there is some visible tissue or body fluids, it should be decontaminated with a 5.25% sodium chloride or sodium hypochlorite at a 1 to 10 dilution. And then you're going to use the hospital's policy on that one. Okay, and when this is infected into the host, you can see here is a normal prion that we have in the body with here's amino acids in a sheet form and amino acids in alpha helix. And when the prion is diseased, we still have the amino acids in an alpha helix, but the sheet form turns into what's called a beta helix. And so this, what it causes here in the histological slide, you can see this looks a little more spongy, and that's kind of the characteristics of CJD, is that the brain begins to shrink and deteriorate because it has a spongy, it turns into a sponge basically. And so you can imagine the symptoms of that. But then we have parasites, and also talking about parasitology, which is the study of these invertebrates that cause disease. But parasites are unicellular protozoans and multicellular protozoans. There is a group called helminths, and these are tapeworms, flukes, and roundworms. And those are the most common parasites that we typically deal with. And this comes from contaminated food or water. It can also penetrate through the skin or fecal oral route. And people say, there's no way I can get a fecal oral route infection. Well, not everyone washes their hands after they have a bowel movement. And you have no way of knowing who has good bathroom habits and who doesn't for your foods that are prepared when you travel abroad. And so you're taking a chance on that. And so that is one way that people are infected. Another way can be barefoot, where there is livestock, because there is a way that they can enter through the skin. Like I was talking earlier, cuticles, toenail cuticles is one way that they can enter. Another is Entamoeba histolytica, and this can be found with patients that are undergoing colonoscopy. This parasite can be found in the colon. Here's some images of parasites, and you can see they'll attach to the intestinal wall. Here is a whipworm. This is a tapeworm, roundworm here, Giardia, hookworm, Buccidia. And here you can see this looks like roundworm or maybe tapeworm, but it really looks like roundworm. And this is definitely what they look like. Okay, then let's talk about fungi. So mycology is the study of fungi. These are eukaryotic organisms, and they can either be one cell, which is a yeast, or multicellular, which is molds and mushrooms. When this causes a disease, when these pathogens cause disease, that disease is called mycosis. And so things that mold causes is mycosis, or certain types of mushrooms or yeast is mycosis. And as we talked earlier about opportunistic and things of that nature, most are opportunistic, meaning that they're looking for an opportunity when an immune system is compromised, such as HIV patients. We'll look at this in looking at the common fungal infections. Here we've got Candida albicans. So we see this a lot with vaginal yeast infections. So think about when does this occur? It occurs after a big dose of antibiotics. Well, antibiotics is going to reduce not only the bad bacteria, but it's also going to reduce the good bacteria in the gut. And so then and in the bladder. So then it leaves room for bad bacteria, bad fungi to grow. And so that's when we'll see the resulting vaginal yeast infection. Also trench mouth, which is thrush, and this can occur in seriously immunocompromised patients that are prone to this, and they can have that infection can go to the brain meninges, to the brain and the meninges and the heart valves, which is a big risk there. So any of your patients that have indwelling venous catheters that we, talked about, like a PICC line or Swan-Ganz, something like that, those those long-term indwelling catheters, as well as someone intubated for long-term, all of these are at higher risk for this infection. We also have several other microorganisms that can cause things like blastomycosis, coccidiomycosis, histoplasmosis, or pneumocystis pneumonia. And so these are some of the most common that you may hear in your work. Okay. So we have a natural line of defense in our skin. First of all, it is a great boundary for us. We have an immune response that provides that recognition of the pathogens and the mounting the army attack. So our immunity is really the key to offsetting any true infection by any of these pathogens we've talked about. You can stay safe and you can keep your patient safe by monitoring and making sure that you're maintaining good hand hygiene, using your PPE, so that's your personal protection equipment, so that's your shoe and hair covers, your gown and gloves, your eye protection, and your mask. All of that is your PPE. Also with good respiratory hygiene. You will be talking in the OR, but it is safest to always breathe through your nose unless you're talking. And so that is a really good respiratory hygiene technique to incorporate, that you're always keeping your mouth closed unless you're speaking. We have a tendency to be mouth breathers, and with masks, sometimes we do feel that we're a little smothered, but if you can just work to get in the habit of breathing through your nose most of the time, then you are practicing good respiratory hygiene. Safe injection procedures. This is just to cut down on needle sticks, as well as safe handling of contaminated items for any possible contamination. Transmission-based precautions. There are guidelines for infection control at every facility. You'll go through that in orientation and learn what their guidelines are. And then there is ways to prevent cross-contamination of patients with diagnosed disease processes, which is why we take those extra precautions with CJD patients, so that in between those cases that we're working to prevent any cross-contamination for the next patient that's coming into that OR. Oh, and here's some pictures of fungi. I guess I got them in the wrong position. So this is a normal, beautiful mushroom. This is the cell that you can see, the makeup of that. This is the little nuclei of the cell. This is thrush, and this is Candida yeast infection of the vaginal walls. And you can see in both of them, it's a white, cheesy type material. And so these can cause these infections. Any infection requires a primary agent, which is your patient or yourself. And so even bacteria, viruses, fungus, all these parasites, all of these require a primary agent. And so your job is to protect that primary agent from any bacteria entering that patient, or if they are already infected, your goal is to maintain that and keep it with the patient and not allow it to move to the next patients that you're having in your OR. There's two types of surgical site infections. There's exogenous and endogenous. Think about endogenous means internal. Remember, endo means in, exo means out. So think about exogenous, that's skin, hair, the nares, the environment, contaminated instruments, anything outside the body. but the endogenous group is the microflora, something that's already within the patient. So take a look at those examples in the book. Now, factors that increase that risk, of course, age. We know that our immune response does decrease with age. Obesity plays a role because of the glucose regulation and the effect that it has on bacteria and viruses and fungi. So that's to be considered. Their overall general health as well, because that influences their immune response. And then if they're carriers of Staph aureus or MRSA, remote infections or preoperative hospitalization, anytime that they were in the hospital before their case. Also pre-existing illnesses and types of related treatments. There's a lot of treatments that will compromise the immune system. So all that has to be considered. Also, if they're malnutrition, and that doesn't always mean that they're underfed, it could mean that they're malabsorption. Tobacco use, diabetes, malignancy, and immunosuppression. Types of procedures that cause greater risk. Pre-op hair removal is important because this is, that colonization, breaks in the skin can occur. And so we want to be careful with that hair removal to make sure that we're not breaking the skin to allow anything to enter. So that's why if you are helping or responsible for the shaving of the surgical site, you want to be very careful not to break the skin because you've just created an increased risk. It also depends on the type of procedure, what they're doing, where they're going, how long the patient's going to be under, and all of that is taken into account. And this is all broken down for you in box 7-2. Oh, won't go there yet. Okay, so now we're going to talk about, let me get over there too. And you can read through this. I know this is a lengthy chapter, but it's very helpful. Okay, so we're going to talk about decontamination, disinfection, and sterilization. All of these are occurring because, you're trying to provide that environment that is safe for the patient, that is allowing patients to come into the OR and have the peace of mind of getting this procedure done and not leaving with something left behind from a previous case. And so, and as well, you're doing that for the next patient as well. So we're looking at reducing that at all costs. 7, 8. Okay. There's some ways that, of course, you can read through this, modes of transmission, how things can be cross-contaminated. It can be contact, which is direct transmission. Just like you see a light handle drops into an open wound, or a hypodermic needle stick injury. So you never want to two-hand recap a needle. You always want to sweep it on the Mayo stand and to recap it. Indirect, so this is the bioburden of contaminants. That is body fluids and blood on the gloves that contaminate equipment, and then it's handed to a non-gloved person, and then they rub their eyes. Droplet, of course, this is airway by sneezing, coughing, or talking. And then airborne spread, and so this is by a sneeze. So let's look at the basic terminology here, and I'm not going to go through all of it. Let's save them 8. Okay, we talked about all of that. Oh, here's some, this is interesting. I was reading through this. AST standards of practice of eye protection during invasive procedures, the laundering of scrub, wearing jewelry, lab coat, hand hygiene, fingernails, head covers, shoe covers, all of that. And then there's a case study that's that is very helpful to read through. Okay, all right, let me keep getting through here. I'll get there eventually. All right, here is terminology for you to review. We're not going to go through all of this, but do notice that bioburden, this is the number of microbes or amount of organic debris on an object at any given time, gross contamination on surgical instruments or supplies. So this is something you're going to be dealing with always, is that bioburden. And so your job is to reduce that bioburden as much as you possibly can. All right, so there are 3 classifications for patients. Critical is the number 1, and this is going to be used for those with a high potential for causing an SSI. It could be an invasive procedure or vascular access. So if you're in a vascular case, you're directly already in the blood system. So there's a very high potential for you helping contaminate a patient directly into their bloodstream. Semi-critical. These are items that come into contact with mucous membranes or non-intact skin, and these carry a lesser risk of infection. So these are things I think of like speculums, the eye retractors, things that are coming into contact with the mucous membranes, even retractors. So all of those, you would think about things that would be used in that. Non-critical, these are items that come into contact with a patient's intact skin and clean environmental equipment, and these pose the least risk of infection. I'm sorry, this is where speculums come in when I'm thinking about it. So just looking at this and thinking about which types of cases and which types of procedures within a case that are going to fall into these categories. Okay, this is document titles. Let me go over here because this is, there is a link from the book for each of these. So this is this standard operation procedure for decontamination of instruments. You can click on it. I'd highly recommend reading through this and scanning through it. And it allows you to see that you're going to keep the instruments free of debris during the surgical procedure. You can wipe it with a sterile water moistened sponge. And then of course, you're going to make sure that sponge is not used on the patient. If they have lumens, then you're going to flush it with sterile, with a syringe to remove the blood, and so forth and so on. So reading through that is going to be very helpful. And then standard operating procedure for packaging material and preparing items for sterilization. And we've watched videos on this. We're going to watch another one tonight where talking about how to do that procedure. And then for monitoring sterility, how do you monitor the sterility? How do you check and make sure that it's sterile and know that it's safe then for your patients? And so process indicators and things of that nature. So this is very good information. You want to make sure you read through that. Okay, and then levels of disinfection, of course. So the purpose of all of this is to remove, one, the bioburden. So this is done with cleaning. So this, you're going to be able to use sterile water and be able to remove the blood and debris from the instrument so that it doesn't dry onto the instrument. So that's really important. You'll be using a brush as well at the end of the case. Disinfection is a different level. And so this is a high level. You could also have an intermediate or low level of disinfection, removing some more of those, the material that could be contamination risk. And then there's sterilization. And this is the way that we're able to really feel safe in reusing the instruments. And then there's different factors that are going to influence the efficiency of the disinfectant process. And that includes the solution concentrate. So how concentrated is it? How long does it come in contact with the equipment? And the physical solution factors as well. So we'll look at some of that in detail. The first one that we're going to look at is glutaraldehyde, and you'll know this as Cidex. This is the high-level disinfectant compounds. The items must be cleared and rinsed prior to being immersed in the Cidex, so they must have no debris on them. They will remain in the Cidex for 20 minutes at room temperature. The book has all of the actions, what it does, the advantages and disadvantages, and you'll want to read through that. You must wear gloves using this, and you want to avoid splashing that, and you want to be careful not to inhale the Cidex. It is a high-level disinfectant, and so it is going to not be safe to inhale. The second one is sodium hypochlorite, and this is household bleach. This will be used to clean the floors, as well as the surfaces and equipment and effective. And when you're looking at like a CJD patient, everything is going to be moved and mopped under, and everything is going to be cleaned on top of as well. So there's different protocols for different risks. There are CDC recommendations for our blood and body fluid spills, and you will follow your facility's procedure on that. And then again, there's the advantages, disadvantages, and actions in the book. For this one, the safety consideration, in my opinion, it's kind of the same as the Cidex, but you're going to wear gloves, mask, eyewear, gown, and apron for this because it will, as we all know, whiten your clothes. It's also not safe to inhale, so you want to make sure that you're wearing protective gear with that one. Now, one step down, so this is an intermediate level disinfectant compound, phenol, which is carbolic acid. This is used it's used as a concentrate when needed, but it's also used diluted with water. This is good to clean countertops and the floors. And you can read all that in the book, the actions, advantages, and disadvantages. And with this one, you're going to make sure you keep on your PPE and your gloves, eye protection, and respirators, because this one is not recommended at all for inhalation. Intermediate level, again, these are called quats, and this is quaternary ammonia compounds. These are bactericidal, fungicidal, and pseudominocidal. You can read all of those advantages, disadvantages, and actions in the book. Again, we're going to have a well-ventilated room. We're going to wear our PPE and gloves. Alcohol is the last or the next intermediate, and you will have isopropyl and ethyl alcohol in a dilution of 60–70%. You can read the AAAs in the book, and then you're going to wear all of your PPEs. You're going to try to not let it pool. Direct contact with your skin is not recommended. And so the importance of maintaining asepsis in all ways is minimizing that microbial count in the OR, because we're looking at keeping not only the patient safe, but each other as well. Hospital exposure plans are mandated by OSHA. Standard precautions in use of the PPE are going to be required, and decontamination of the OR. So all of these are really important when we're trying to maintain that asepsis standard. Environmental services, and you can read in your book a lot about environmental services, but this is really important to read through about how that environmental services is tending to the OR during our cases, between our cases, and at the end of day. So I highly recommend reading through all of this and seeing prior to the first procedure of the day, environmental services, you've got to be super friendly to these guys because they're saving you here by keeping everything really nice and clean for you. They're cleaning all the surfaces, ceiling to floor. And then during the procedure, there is some on your responsibility that you're going to be busy during the procedure, of course, but you're also going to be paying close attention to when there's a break and you have some downtime, that you're you're utilizing it with like a basin of sterile water for soaking and cleaning of instruments. And you're going to make sure that you're never using saline. So saline is our second keyword, that we're not ever going to use saline, and mention that it causes pitting of our equipment if we use saline, because it erodes the metal. So make sure that you mention saline and causes pitting. Write that down. And so the circulator is also going to be doing some intraoperative cleaning, such as gross spills or things of that nature. Decontamination between procedures. And so things like the suction containers are going to be changed out. You're responsible for disposing the sharps. The linen and trash is going to be sealed, and all of the instruments are going to be placed back in the case cart. And this is your responsibility of making sure that that's all together to go to decontamination. In some facilities, you'll actually take it to decontamination. And at the end of the procedure, you're going to load the case cart, and then it's transferred to the central sterile processing department. Here, of course, is a case cart that you'll be loading to go back to the decontamination area. And then there's a thing called terminal cleaning. This is really important. This is at the end of the day. Terminal cleaning is also done anytime that there is a possible contamination in the room. So somebody that's suspected of CJD, usually that OR is cleaned or is closed for a terminal cleaning. And there's certain pathogens that they will close an OR for a terminal cleaning. But this is typically done at the end of every day. And you can see it entails much more detailed cleaning, including the wheels and all of the surfaces. And then the floor is dried, and then there's more cleaning done. So there's weekly cleanings that are more in depth. And then, as I just mentioned, there's some cases that we call them dirty cases, and then those usually a terminal cleaning is done after that too. Okay. All right. And so, of course, you know, you're going to be doing some cleaning. You're going to be pre-soaking those grossly contaminated items. There is a, I think there's a picture in here somewhere. I don't remember exactly where it's at, of the process that goes through. So the first part of the cleaning decontamination process, of course, is that you're going to clean any gross debris off of it with a basin of sterile water and your brush, and you have to pre-soak some of them and clean those instruments off. And then, of course, you're going to get those ready to transport. Once they're in the decontamination area, they go into a washer decontaminator and get any remaining debris off, and washer sterilizer or ultrasonic cleaner. And those instruments that need special care, such as endoscopes, those are going to be cleaned in a very specific way. And then lubrication, of course, this is going to be taken into consideration, which helps like the optimal function of things, because sometimes this cleaning can be drying to some of these instruments that have parts that can be affected by that process. Okay, let's see. Let me get over here to this. It is figure 7.6. That's the picture I think I'm looking for. There it is. Yeah. So we are going to use a piece of equipment on the patient, and then we're going to sort and disassemble. So we're taking some things apart that are needed. They're going to go into the ultrasonic cleaner to get cleaned. Sometimes that takes some manual work as well before they go in there. Then they're going to put through a decontaminant, a washer sterilizer, and then they're going to get inspected by the central sterile processing team to make sure that there's no remaining debris on the equipment. And then they're assembled and wrapped, and then they're sterilized. So they're already wrapped before they're sterilized, and then they're stored for the next case. And so packaging, let me get over there. there's 3 different characteristics of the wrapping we want to talk about. Here it is. So the packaging has to meet 3 performance standards. They must be able to maintain the sterility of the items until use. So once they're sterilized, they have to be impervious enough that that sterility will not be jeopardized. Also, they have to be able to be open in a way that sterility can be maintained, but that is easily accessed. So as you're opening up a tray, you've got to be able to open it in a way that you're not going to contaminate anything, but that there's easy access. And then also the packaging material has to allow that sterilizing agent to penetrate into the equipment and reach every surface of those instruments that are to be sterilized. And so you can see there's different types of textiles. You can read through those. And the woven textiles with barrier properties and muslin, you know, those are considered in a different way. Let me get, where was that at? Here we go. This is it. So we're looking at things that are made out of cotton or blends, such as polyester. You know, those are going to be used over and over, you know, but then fibers are lost and that increases the space between the threads. And so then that is reducing that barrier. So eventually the wrap has to be discarded if we're talking about using something that is cotton or a cotton blend. And so what we're seeing most days are the disposable, right? So we're seeing the paper ones, because the things that are used with a barrier property, these are there's chemical treatments added to the fabric, and that makes them moisture resistant. So some of the things that we use do have those barrier properties. So then you can read through all of the textiles. So rigid instrument containers are preferred, of course. You know, when you get those trays, they're in the stainless steel trays, and that is definitely preferred to keep everything in place. There is a general principle of packaging things, so they're done in a very specific way in Central Sterile. So it just helps when training new personnel that everything is done the same way, and it increases the safety of the staff that everything is done the same way, especially dealing with a lot of sharps as they are. Okay, so the envelope fold, this is very specific. I did see a picture of it in here. Now, we're going to watch a video on this. Here we go. Here's the video. Here's the wrapping. So it's very specific, and it's done the same everywhere, basically, so that this ensures that as you go to work in any facility, as you go to open them up, it's all pretty universal. So there is an item placed on a wrapper with the addition of the chemical indicator. So here's the indicator here. Then their first fold is with the tab. So these tabs are always going to be placed for easy removal without contaminating the tray. And then the second fold also has a tab. Then the final fold is tucked, and the package is secured with a chemical indicator tape. So the labeling is important. So that tape is then written on with a date and what it is, and the initial of who wrapped it. Julienne date, that is the date of the sterilization. And so it comes with the number of the calendar year. For example, March the 1st, 2015 is 60, and March 11, 2015 is 70. And so that is the number of the calendar year. So 1 is January 1. So that's usually how they're dated. Okay, there's a steam sterilization area that you see. So steam is used, of course, with pressure and chemicals to provide the most optimal outcome. Moisture is going to be included as well, because this, with that saturated steam, is going to, under that pressure, is going to kill those microbes. And so this is the most effective way to kill the microbes, is with that pressurized steam. And so here you can see that most, if we're using steam and dry heat, most surgical instruments are going to be sterilized. If we're looking at powered instruments that are used in cases, these can be, it can be used with thermal steam or dry heat, or it can also be used or be cleaned with gas, like ethylene oxide or gas plasma. And then when we're looking at micro instruments, you can see they're needed in the steam dry heat, and fiber optic instruments, things of that nature are needed the gas sterilization. Now the chemicals, so like Cydex and things, so these are lensed instruments, fiber optic instruments, and cables, heat sensitive instruments. So thinking about like your endoscopic cables, like all of that's going to be cleaned with Cydex. Okay, and then figure 9. Let's see what figure 9 was. I think that might have been the picture of the, yeah. So that's just, this is the steam sterilization area, and we'll watch the video here in a few minutes. And then we take into account how long it's in the sterilizer, how is it able to make contact with every piece of equipment, what's the temperature, what's the level of moisture, what's the pressure and the flow of air. And so all of that is taken into account when we're looking at how efficient that is done. So we're going to talk now a little bit about an autoclave. We actually have an autoclave at the school. Well, I guess I passed it already. An autoclave can be a small, oh, they've labeled it wrong. So a autoclave, well, this is the autoclave, but it shows it differently. So it's just showing the panel. So an autoclave is on a small scale is basically, it looks like a little microwave, but you can put your equipment in there, wrapped it, of course. You can also put peel packs in there and set it accordingly, and it will steam autoclave the equipment. So I'll ask some of the techs to show you that. There's also different types of sterilizers. There's a gravity displacement sterilizer, and this relies on gravity, of course, to remove air from the chamber. Then there's a dynamic one, and in this one, there's a vacuum pump built into the system to remove the air. And then an immediate use system. This is when there's unwrapped items. So just different types of sterilization. Of course, there's always going to be some caution with these big sterilizer machines. You know, they've got these huge doors on them, and so you have to make sure that those doors are tightly closed before they start it. There will be an exhaust valve that you have to ensure that that pressure is at 0. And you never want to touch that sterilizing cart, because remember, that is heat, it is steam. So, okay, let me stop the share just a moment. Okay. All right, I wanted to look at. Give me just a second. Yeah, there you can see the indicator tape with the writing on it. That indicates that it's been adequately sterilized. So the next topic I wanted us to look at was troubleshooting, okay? So as you read through your book, you're going to see that if there is moisture on the inside of the pack, that could be because there were too many instruments placed in the tray. It could also mean that there was not the absorptive towels, which does soak up the extra moisture. If things that are wrapped in such like towels or things like that, they could be wrapped too tightly, so then they're not allowed to breathe that moisture out. And so things that are improperly loaded on a sterilizer cart, and so then moisture is going to be able to collect in the package and not going to be able to escape. So gas sterilization, of course, the ethylene oxide is the primary chemical that's used in this process. And so it's effective against all forms of both microbes and sporicidal. One thing about this is that it is a risk to employees to be exposed to it. And so that's why it's done in that closed room. And so you want to make sure that you're not exposing yourself to it. And so that's why the system is pretty tight on not allowing that. So some of the things that could happen if you're working in central sterile department is, and the sterilization is not being completed, you want to look at the ETO gas concentration, making sure that that is adequate. If the temperature is not between 85 and 145, it won't be effective. And the humidity, of course, has to be between 30 and 80%, and the time. So the time is going to, of course, it's going to be different depending on the contents, but it is a very lengthy process, I'm sorry. So these are some ways that you can, monitor if there is some issues with that ETO sterilization process. You can look at all of those troubleshooting ways. Also, hydrogen peroxide gas plasma. So this is used at a low temperature. And so these are for more sensitive things, things that cannot handle the super high moisture, heat and sensitivity and pressure. And so this is a lot safer than ethylene oxide. So it is being replaced in a lot of the healthcare facilities. There is the only thing is that there's a strong electrical field created by this gas state of hydrogen peroxide. So that's to be considered, but the cycle time is only 28 to 38 minutes. So that's a time saving. There's also liquid chemical, which is peracetic acid or glutaraldehyde. And so this is a 23-minute cycle. This again can be for things that are heat sensitive, but that are stable under that moisture. Ionizing radiation. This is industrial manufacturers are going to use this more. This is ionizing gamma radiation. So prepackaged products that come in already prepackaged, those are usually prepared in that way. And it does use a process of radiation, which is able to eliminate all microbes and spores because it disrupts their DNA. Ozone gas is also used for bacteria, and it will destroy those. And then vaporized hydrogen peroxide is also used as another form. Documentation is key in this. So, the test results have to be filed as a permanent record. So when you're unpacking your trays and you indicate that it does have a positive indicator, the circulator is going to be charting that. So everything is charted. through the whole process from central sterile to the case and as a part of the case. Preventive maintenance measures are always documented on all the machinery, and mechanically generated printouts are always documented because the machines are constantly running calibrations and things of that nature to maintain that sterility. And then the administrative sterilization process log. So everything is documented according to procedure. So the sterility of an item is determined by how it is handled. So, and that means that it is what they call event, that contamination is event related rather than time related. Let me show you where that is. When we're talking about an event contamination, this is a long chapter. You're thinking, I know, right? But it's pretty interesting to understand all of this. Here we go, event. Okay. So it used to be called time-related sterility. So did I? Oops. Okay. Okay. What I was saying was that in the past, the sterility was called time related because there was expiration dates on all of the wrapped packages. And then they pretty much figured out, as the process continued to improve over the years, that once it was sterile until that was broken. So they changed it to what's called event related sterility. And all that means basically is that that package is sterile until it's opened, or until the seal is broken, and then it is no longer considered sterile. So just read through that and make sure you fully understand that. Yeah, and they went to that because economically it was more profitable to leave things as it is instead of redoing it just because it expired. And so, of course, JACO and HMI have changed their standards on that. That's what I was saying there. Now, surgical conscience, of course, this is you being conscious and practicing that strict adherence to sterile technique, because all surgical team members, that is the goal. That is the third key term, is teamwork, because you're all working together on making sure that you are helping each other stay sterile and improve on your skill sets. And I know that the Deanna is working with you guys last week and this week on doing things of that nature, where you're monitoring someone who is skilled and in the OR to see if you're able to pick up on anything that is done that needs improvement or on purpose. So it just helps you get in that habit of watching your team members and yourself to maintain that responsibility to the patient, you know, so there's no compromise of sterile technique. Now, these principles, you can find them in this box 7-3, and look at the recommended standards of practice. So feel free to read through all of these to see how you're going to do that when you're creating a sterile field, practicing for a bow technique, underside of Mayo stand, how you maintain that sterility, surgical drapes, gowning, gloving, so on and so forth. So, you know, principle one, though, is that your sterile field is created for each procedure. The team members must be appropriately attired prior to entering, and then movement in and around the sterile field must not compromise the sterile field. So what we definitely want you to be the most conscious of is guarding that sterile field at all costs. We are okay with strong protection of that, and we hope that we're teaching you that. So in summary, this chapter, you've learned about principles of asepsis, sterile techniques in surgical patient care, and the concept of surgical conscience. And then we looked at principles and procedures related to disinfection and sterilization, and the application of these principles in the sterile and in the surgical environment. So I'm going to stop my share a moment while I queue up a video for you guys to watch. Okay. You guys are familiar with these, but this is another one on, just want you to see again the central sterile, because now as you're learning more about that, you're able to relate it. So it's going to take me just a minute to get this loaded up. I know you watched it before, but let me get through this. Okay, let me share the screen. Let you guys watch this.
The primary goal of all healthcare personnel is to provide quality care to the patient. Each member of the healthcare team significantly contributes to achieving this objective. This is equally true for the surgical technologist working in central sterile processing. Proper cleaning, disinfection, and sterilization are necessary for sterile technique to be achieved, and consequently, for the safety of the patient to be controlled.
You break the sterile field, you're compromising the patient, you're not compromising yourself, and you must keep that in mind at all times. It is the patient that is number one. That's why we're here.
It's our job to make sure they're safe and kept well and provide the safest environment for them as possible.
Central sterile processing functions under the principles of asepsis through proper cleaning, disinfection, and sterilization. It is the responsibility of central sterile processing to follow every guideline of instrument and supply processing to the letter.
We don't want any type of non-sterile contaminants touching our equipment, touching the patient or the doctor, so that it can be passed on into the patient as we are operating.
These practices begin upon the completion of a surgical procedure. Instruments are cleaned of any gross contaminants by the surgical technologist and then are disinfected manually or by the use of washer decontaminators. After decontamination and disinfection, these instruments are taken to the clean processing area where they are inspected, sorted, reassembled, and wrapped for sterilization. The potential for exposure to blood-borne diseases such as hepatitis or HIV is high in the OR and of major concern. Accidental injuries from sharps and the splashing of body fluids on skin or mucous membranes can occur often in the operative environment. The best protection is the use of standard precautions, which include double gloving, use of face shields or other acceptable eye protection, careful use of sharps, and the use of gowns, which provide a level of protection from strike-through contamination. When breaks in sterile technique occur, for whatever reason, the patient is exposed to a preventable risk. Errors, therefore, should be noted, communicated, and corrected immediately.
If you don't know for sure, the saying is, when in doubt, throw it out. It's much easier just to get rid of that, not risk the potential of contaminating your patient or contaminating a sterile area on the field, and obtain a new instrument or a new cloth or a new bandage or whatever it is that may have been contaminated. Again, when in doubt, throw it out. You don't know, so why take the risk?
The first step in the decontamination process actually begins at the point of use. The surgical technologist who used the instruments and equipment is responsible for preventing the drying of organic material such as blood and tissue. Only sterile water should be used to soak instruments during the surgical procedure.
Once the patient leaves the OR, the surgical technologist may begin breakdown of the setup. If needed, put on additional personal protective equipment, PPE, such as non-sterile gloves. Protective eyewear should not be removed during this process. Remove instruments from the Mayo stand and open or disassemble them as required. Place them in a basin of sterile water to clean them of any gross contaminants. Place the basin containing the soiled instruments on the case cart. If at all possible, place the instruments in a closed system for transport. Replace instruments from the back table that were not used for the procedure into the instrument tray in an orderly fashion. Placing unused instruments in the instrument pan will make it easier for the central sterile processing personnel to distinguish which instruments need to be cleaned first, and will make their job easier as they prepare the instrument set for the process of sterilization. Place the instrument tray in or on the case cart. Caution must be taken to place flexible and rigid endoscopes on top of all instruments. They should be placed on a towel or some other cushioning device. This will not only prevent damage to the scopes, but will also make it easier for central sterile personnel to identify these delicate instruments and take the necessary safety precautions in handling them. Take the case cart to the decontamination area, where the instruments will be further cleaned and then disinfected. Remove and discard all PPE. Always perform a hand wash after removing your gloves. Tip: caution must be taken to ensure that all sharps have been properly disposed of prior to placing instruments in the cart for transportation. Exposed sharps are extremely hazardous for personnel in central sterile processing.
The following solutions may be used for soaking the instruments after the surgical procedure: tap water, detergent solutions, enzymatic solution, a proteolytic enzymatic cleaner which facilitates the removal of protein materials such as blood, a lipolytic enzymatic cleaner facilitates the removal of fatty materials such as adipose tissue and bone marrow.
Surg techs do have a responsibility in the operating room to make sure that their instruments are in a solution. Before they go downstairs, they're in sterile water, get some of the debris off. It's the folks in the SPD unit that break down our instrument sets for us. They inspect our instruments to make sure that they're working, well oiled, that they're not broken. They clean them, they disinfect them, they sterilize them. If it wasn't for them, the OR would not run efficiently at all.
Tip: never soak instruments in saline. Salt will pit the stainless steel finish, permanently damaging the instrument and leading to the formation of rust.
Saline solution is bad for instruments because it has the same effect as ocean water on cars down at the shore. The salt causes a pitting effect on the metal, which ultimately deteriorates the instruments.
Cleaning of surgical instruments manually or mechanically is the first step when instruments arrive at the decontamination area. Various detergents, enzymes, and cleaning agents are used to break down fat, oil, and grease, and break down soil into fine particles to aid in removal. PPE must be worn for all cleaning processes. If mechanical methods of cleaning and decontamination are not available, or the item to be cleaned cannot undergo the stress from mechanical cleaning, they must be manually or hand cleaned. It is recommended that delicate instruments, such as endoscopes, always be manually cleaned and decontaminated to preserve the integrity of the instrument. The purpose of manual cleaning is to physically remove debris that was not removed or softened during the pre-soak. Ideally, a 3-sink arrangement is utilized as follows. First sink, wash sink with water and detergent or disinfectant detergent solution. Second sink, intermediate rinse. Third sink, final rinse with distilled water. Detergents are selected according to the type of instrument to be cleaned. The manufacturer's instructions must always be followed for correct dilution, temperature, and use. A neutral pH detergent should be used for the manual cleaning of surgical instruments because strong detergents may damage them. Instruments should be rinsed with distilled or demineralized water and then dried. The use of distilled water for rinsing adds years to the life of the surgical instruments and prevents mineral residue buildup.
Immerse instruments in a solution of water, detergent, and/or enzymatic cleaner with a neutral pH. The enzymatic cleaner is to aid in the removal of bioburden. Items with multiple parts must be disassembled before cleaning. Individually clean each instrument with a soft bristled brush in order to apply friction to loosen the organic debris. The foundation of manual cleaning is friction. Friction will loosen the organic material to allow its removal during the rinsing process. Keep the instrument and brush submerged in the solution while cleaning to avoid contaminated water droplets from aerosolizing. Direct particular attention towards serrations on jaws, ratchets, box locks, and teeth of forceps. When cleaning stainless steel instruments, a back and forth motion should be used to follow the grain of the instrument, rather than a circular motion which can scratch the surface of the item. Instruments with lumens may be cleaned with a tube brush, pipe cleaner, or handheld water pressure gun. Change the cleaning solution frequently to avoid buildup of microbes and soil. Perform the intermediate rinse in the second sink. The last step is to rinse the instruments in distilled water. Do not use tap water due to the presence of minerals that can stain and form a film on the instruments when the tap water evaporates. To avoid spotting on the instruments, the items should be immediately dried after rinsing.
Watch this scene carefully. What are some examples of improper technique used in this scene?
The problem with an instrument or pack being wet is that it adds moisture to the instrument, and when there's moisture in the instrument, that allows a breeding ground for microorganisms and bacteria and stuff that shouldn't be there. So the importance of that, of not having moisture, is so that it decreases the bacteria count, which then will decrease infection within the surgery.
protect individuals responsible for the decontamination of surgical instruments and equipment, many healthcare institutions have purchased mechanical cleaning equipment to eliminate manual cleaning and decontamination. Decontamination is the process that combines cleaning and disinfection. After manually cleaning instruments of gross debris, decontamination of instruments is accomplished by cycling them through a washer decontaminator or ultrasonic washer. Decontamination is the first step in the prevention of transmission of microbes from instruments to patient or from instruments to personnel, and renders the instrument safe for handling by OR and sterile processing personnel.
It's the most important thing because we're waiting for instruments, we're waiting for this. You know, if we have to call back down to have something brought back up and we have a patient asleep on the table, that's compromising their care, which then has the patient under anesthesia more often. And sterile processing is just as important as the actual surgery because you have to make sure that we have the instruments. They have to be wrapped properly and just make sure everything goes smoothly. It all has to fit into place.
Instruments must first be cleansed of gross debris and placed into a perforated tray to prevent interference with the cleaning action of the machine. Place heavier instruments on the bottom of the tray to avoid damage to the lighter, more delicate instruments. Hinged instruments must be left in an open position to allow water, cleaning agent, and steam to contact the total surface area. Instruments with attachments must be disassembled. Instruments with concave surfaces should be placed upside down to allow proper cleaning, rinsing, steam contact, and drainage. A slightly more alkaline detergent is usually used for automatic machines. This compensates for the lack of friction achieved with manual cleaning. Low sudsing detergents must be used in mechanical equipment to avoid damage to the equipment.
Ultrasonic washing is not considered a true disinfecting process, but rather another method of cleaning instrumentation. The cleaning solution must be frequently changed due to the increase of bioburden with each use. The UW process creates fine aerosols that may contain microbes harmful to personnel, so whenever the UW is in operation, the lid must be closed. When the solution is changed and the chamber refilled, gas bubbles form, decreasing the cleaning effectiveness. Running an empty cycle degasses the chamber.
If they aren't doing their job well, our job doesn't get done. If we receive instruments from them that are dirty or have been wrapped inappropriately, or there haven't been the indicators put into the packaging, that delays our job and it delays the procedure, which will delay the surgeon.
After instruments are cleaned, they must be checked for cleanliness, functionality, and integrity before being prepared for sterilization. You must make sure that no blood or soil remnants are left after decontamination. This activity takes place in a room designed for that purpose and commonly referred to as a clean room.
Instrument function must be determined for repair or replacement. The following are general guidelines to follow for functional testing. Traditional surgical instruments, like scissors, hemostats, and clamps, can be easily inspected under normal lighting. This process should include the ratchets, box locks, serrations, and lumens. As the inspection for cleanliness is taking place, it is easy to also identify any broken or damaged instruments. The cutting edges of scissors should have no burrs or cracks. The blade should close smoothly. Scissors should be sharp enough to cut 2 4x4 sponges with little effort. The instrument's ratchet must be checked to ensure that it locks properly and will not spring open. If the instrument is tapped lightly in the palm of the hand and the ratchet remains closed, then the ratchet is working properly. Ratchets on self-retaining retractors should be checked to make sure they remain locked in the open position and release with little effort. The jaws of clamps should close evenly with no gaps, and the tips should be evenly lined. Forceps should close evenly with tips evenly lined. Tissue forceps teeth should fit smoothly in the groove of the opposite side. The points on non-disposable trocars should be inspected for burrs, cracks, scratches, or bends. Dull or burred trocars make insertion difficult and can not only be traumatic to the patient's skin, but also could possibly lead to inadvertent puncture of vital organs. More complex devices, such as endoscopic instrumentation, contain areas that are more difficult to reach while cleaning and require thorough inspection, which involves direct visualization into the lumen. Flexible instruments should be thoroughly checked for damage to their seals that could cause damage during the sterilization process and also harbor dangerous microbes. Manufacturer's instructions must be followed for proper inspection of powered instruments. The instrument may need to be lubricated and operated for a designated amount of time for lubricant distribution. The power hose should be checked for cracks and cuts. Damaged or broken instruments should not be returned back to the instrument sets. They should be tagged and replaced with a properly functioning instrument.
As far as surgical instrumentation goes, teamwork is vital because you need to make sure that your instruments are all together, that you have all the instruments that you need for a case, and that they're in working order. You don't want to have a surgeon use a pair of scissors on maybe a blood vessel and find out it's dull and it accidentally chews the blood vessel out, and you have to get a new pair.
After an item has been prepared for sterilization, it must be placed within a rigid container or wrapped. The use of two wrappers applied in a sequential manner ensures that the contents are adequately protected. The outer wrapper is securely closed with chemical indicator tape, and the tape is labeled to aid in identifying the contents. The user must be able to identify the contents of a package, especially when a woven or non-woven wrap is used. Items within paper plastic peel packs can be seen but should still be labeled. Items are also labeled for quality assurance, inventory control, and rotation of stock.
Assemble all necessary supplies. It is important to choose the correct size wrapper. Too large a wrapper can inhibit the penetration and release of the sterilant. Too small a wrapper will not adequately cover the contents and could possibly tear at the corners. If the wrapper is to be used for the establishment of a sterile field, it should be large enough to extend to a minimum of 6 inches below the 4 sides of a table or basin ring stand. Before wrapping, it is advisable to place an absorbent towel between the bottom of the tray and the wrapper, especially if the wrapper is non-woven material. If necessary, another towel may be placed on top of the instrument tray before wrapping. The towels cushion the sharp corners of the instrument trays and prevent tearing. Place a layered wrapper diagonally on the table with a corner pointing towards you. Center the instrument set on the towel and place a sterilization indicator on top of the instruments so it can be readily visualized when the set is opened. Fold the near corner over the instrument set. Create a tab by folding 2 to 3 inches of the corner back onto itself. Fold one side of the wrap over the instrument set as far as possible. Create a tab by folding 2 to 3 inches of the corner back onto itself. Fold the opposite side of the wrap over the instrument set as far as possible, overlapping the first side of the wrapper. Create a tab. Fold the final flap over the instrument set, overlapping the other sides. Bring the corner of the wrapper around the outside of the package and secure with the appropriate tape, which may also serve as the external indicator. The packages should be labeled before being sterilized. Most facilities use a felt tip quick-dry permanent marker for labeling. All the information can be recorded on the chemical indicator tape or on the front plastic portion of the peel packs. However, it must be noted that when labeling wrapped instrument sets, markers should be used on sterilization tape only. This will prevent bleed-through contamination of the item to be sterilized.
Written label information should include package contents, shelf life indication, either the expiration date or indication of event-related sterility, date of sterilization, identification of the sterilizer, usually by number designation, cycle number, initials of the employee who prepared the package, department to which the package is being sent. Many institutions use a label gun that discharges printed labels onto the chemical indicator tape. The printed label usually contains Julian date that indicates the date of sterilization, identification of the sterilizer, cycle load number.
I wish everyone in sterile processing understood how important their job is, how important it is to have things wrapped correctly, how important it is to have an indicator in there.
They open up a container to find out that the indicator hasn't been in the container. Okay, the patient's already in the room, nothing's set up. So we have to call back up to sterile processing department to get another instrument container into the OR. That takes maybe about 10 minutes. So there's 10 minutes of time that we've wasted. The patient's probably already under anesthesia. The surgeon's waiting at the door.
There are numerous types of sterilizers in use today. Pre-vacuum steam sterilizers have a built-in system to remove air from the sterilizer prior to injecting steam into the chamber. This will help to reduce the total cycle time. When preparing to operate any steam sterilizer, the surgical technologist must always keep safety their top priority because steam can cause severe burns to the careless operator.
Approach the sterilizer door with caution. Stand behind the door of the sterilizer as you prepare to open it for placement of instruments. Open the sterilizer door slowly. Center the instrument carriage with the sterilizer and lock into place. Carefully advance the carrier into the chamber. Care must be taken not to touch the sides of the chamber. Remember, you are dealing with very high temperatures, 270 to 276 degrees Fahrenheit, or 132 to 135.5 degrees Celsius. That can burn your arms if you accidentally bump the chamber as you place the instruments in the sterilizer. After carefully closing the sterilizer door, secure and lock the door prior to beginning sterilizer operation. Push the appropriate start cycle button to begin the process. In a pre-vacuum steam sterilizer with a wrapped instrument set, the temperature should reach 270 degrees Fahrenheit. The sterilization time will be 4 minutes. It is the surgical technologist's responsibility to make sure the correct temperature is reached. Once the cycle is complete, the surgical technologist will open the sterilizer with the same caution as mentioned in steps 1 through 3.
Without sterile processing, we can't get our instruments, we can't get our needed supplies to actually proceed with the surgery. So they're actually the first step. If they don't get it to us, if they don't get it to us correctly, if it's not correctly packaged, if it's not, correctly sterilized, it stops the whole line. Because, we can't do anything without our instruments, without our supplies and stuff like that. So sterile processing is actually the first step in our line of teamwork.
The primary goal of all operating room personnel is to provide quality care to the patient. The safety of the patient depends on strict adherence to the practice of sterile technique by all members of the surgical team. It is the responsibility of Central Sterile Processing to follow every guideline of instrument and supply processing to the letter.
Okay, that's all I got for you. So remember your key terms, and let me know what you learned the most from the videos there at the end. Just give me a tip about what you learned that was new or that you realized. So appreciate you all, and I'll get this loaded.